Hi, I'm Dr. Bevin Campbell, and today I'm speaking with Dr. Enrico Gnaulati as part of a series of conversations produced by the Psychotherapy Action Network, a global community of mental health professionals and stakeholders dedicated to promoting psychotherapies of depth, insight, and relationship. In this series, we're going to be speaking to authors, researchers, academics, and policymakers, many of whom serve as advisors to the Psychotherapy Action Network, and all of whom are concerned about the current state of mental health care practices and policies. We're going to be hearing what some important voices in our field have to say about the future of psychotherapy. As I said today, I'm thrilled to be speaking to Dr. Enrico Gnaulati. He's a clinical psychologist based in Pasadena, California, and an affiliate professor of psychology at Seattle University. He's published numerous journal and magazine articles, and he and his work have been featured on Spectrum News, Al Jazeera America, China Global Television Network, public radio stations across the US, in addition to in The Atlantic, The New Yorker, Huffington Post, Maclean's, Psychology Today, and Psychotherapy Networker. He also blogs for Mad in America. He is a nationally recognized reformer of mental health policy and practice, and he is the author of the book Saving Talk Therapy: How Health Insurers, Big Pharma, and Slanted Science Are Ruining Good Mental Health Care, published by Beacon Press in 2018. He also wrote Back to Normal: Why Ordinary Childhood Behavior is Mistaken for ADHD, Bipolar Disorder, and Autism Spectrum Disorder. Dr. Gnaulati is also an advisor to the Psychotherapy Action Network, and we're very proud that he has lent his support to the organization. Enrico, thank you so much for joining us. So
I'm grateful to be interviewed. Thanks.
You write in the introduction to Saving Talk Therapy that the primary aim of the book, and I'm going to be quoting here, is to document and help preserve the practice of traditional talk therapy at a time when its availability is in decline. So for those watching who might be unfamiliar with your work, how do you define traditional talk therapy? What is it, and what might a patient experience when they take part in it?
Well, I think good, wholesome talk therapy avails and allows the client to kind of really settle in, have ample time, and I can't emphasize that enough. They get the gift of time to really settle in, lift the veil of pretense in their life, be as candid as possible in ways that allow them to kind of feel the unfeelable, think the unthinkable, say the unsayable, and that process gives them great relief. I mean, it's expected, for instance, that in the telling and retelling of life problems, that clients will just sort of jump around in the way that they narrate their pain and suffering. So there's no expectation that they make sense in any rational kind of prescriptive way. This is how humans storytell. This is especially how humans storytell when they're in a state of agony. So it's expected that clients will jump around in the way that they tell their life story, and that eventually something in the process of jumping around, something will jump out that's meaningful or important for the therapist to kind of pick up on and steer the client. You know, there's no expectation that clients speak with medical ease about their subjective experience in the discourse of symptoms, right? Certainly not medical symptoms like sweaty palms or you know, rapid heart rate, or the sorts of things that physicians might be attentive to. There's an openness and willingness and invitation to really characterize their pain and suffering in everyday ways, with existential concerns like you know, being stuck in a loveless marriage, or feeling trapped in an unfulfilling career, or taboo topics like loving your daughter but not liking the person that she's becoming, and a variety of other thinking that you wanted to be a mother but feeling awfully oppressed by all that involves in contemporary culture. These sorts of taboo topics are invited in good quality talk therapy. There's symptoms of anxiety and depression are not to be categorized, managed, and eliminated. They are taken to signify deeper psychological concerns, perhaps like thwarted grief over important life losses, or once again maybe feeling like you're in a career that you got gravitated towards as a means to please others, not based on natural talents and abilities actually have. So these sorts of existential concerns make up the topics of therapy, not kind of symptom-based kinds of conversations. And perhaps most importantly, there's the expectation of the confident expectation of sustained empathic receptivity on the part of the therapist, knowing session in and session out that you have someone sitting in front of you who's there in a caring way to invite you to tell your story in ways that the therapist responds to from within your subjective frameworks and is empathic in that way, in a sustained way, not just intermittently, but in a sustained way, really frees clients up to have full thoughts and full feelings about themselves and important others in their lives, and gives them the opportunity to acquire, those are the conditions of safety and trust that makes fully open up, that really fully open up. In fact, there's some studies that show that the real work of therapy doesn't happen until about a year in. Jonathan Shedler and I co-wrote an article that was in Psychotherapy Networker earlier this year, looking at that, the sort of the irony of that a lot of abbreviated therapies foreclose the kind of longevity to the therapeutic experience that allows for real conditions of safety and trust for the client to really open up and get to the meat of the trouble in their lives. And in the process, the main goal essentially is better and better expressive mastery of emotion. That's what I consider to be central to the therapeutic process. And in so doing, clients then feel that they're the subject of their emotions, not subjected to them, in ways where they often feel flooded and overwhelmed by emotional experience, and then need to shut it down. They either become implosive, causing anxiety, or explosive, causing anger and disruption in their interpersonal relationships. So the greater the expressive mastery of emotion, that directly, I think, correlates to, a sense of emotional self-control, reflectiveness, non-reactivity, personal agency, feeling like you are the subject of your own life rather than subjected to life.
Right.
That is as best as I can kind of encapsulate kind of quality talk therapy.
Well, you sort of went ahead and answered my next question, which is, why is it important to preserve access to this type of treatment? And one thing I heard you say is that the ability to articulate oneself and one's experiences to the fullest extent possible in therapy is key. And I wonder what you think about, in your mind, why having widespread access to this kind of treatment is necessary.
Well, just from an ethical scientific standpoint, Bevin, the research is clear that time-intensive, open-ended psychotherapy, where clients are given ample opportunity to really explore what truly troubles them in life, is what leads to sustained, meaningful, and lasting change. So for clients to get better and stay better, it's that in-depth, exploratory, mostly non-directive psychotherapy from a ethical, scientific standpoint that really is conducive to meaningful and lasting change. At a more philosophical level, and I get into this in the last chapter of my book, the kind of therapy that I just described is one of the few socially sanctioned spaces or arenas where people who have lived lives of over-compliance and over-accommodation have any shot of acquiring an authentic sense of self. You know, being able to think and act like they're the agent of their own self versus the agent of someone else's will, to respond to the needs of others without surrendering agency in productive ways, and to be able to assert one's self-interest and be in conflict about that, because that always can interfere with respecting the interests of others. And so these phenomena that create, I think, authentic selfhood, especially in this day and age, are extraordinarily important for a healthy democracy. We need legions of people for a democracy to work that have enough of a sense of authentic selfhood that can think both with and against tradition, who see the good and the bad in themselves and the good and bad in others, where they're not prone to always dichotomize and see them as all good, others as all bad, to respect the otherness of the other. These kind of psychological capacities, I would argue that quality talk therapy is perhaps one of the few socially sanctioned arenas where legions of people can acquire those psychological capacities. In this day and age, when our democracy is under threat, quality talk therapy is even more important for these very reasons.
It's a really interesting place you take saving talk therapy to expand the importance of preserving traditional talk therapy is not just a public health issue, you're saying. It's about our democracy. It's about, as you say, the social good, which I thought was a very interested and unexpected place to take it. I want to go back to the book again, in case, you know, people who are watching haven't read it. So you focus on these three issues that have, in your view, really contributed to a de-emphasis on open-ended relationship-based therapies. So one is the dominance of CBT approaches in training and academia. And then there is the skyrocketing use of medication as a first-line response to mental health issues. And finally, the rise of managed healthcare. So I'm wondering if you could sort of briefly, maybe not briefly, take us through how are these factors important? Like, why have they contributed to us, you know, the average person seeking therapy at this point in time, having a more difficult time finding the kind of treatment you're talking about?
Well, it's sort of all crept up on us. I mean, let's not make any mistake about it. Talk therapy is still extraordinarily popular among Americans. If you look at surveys, about 75 to 90% of people would rather talk to a professional about their problems than go to a physician and get medication. Yet that gets flipped. Probably about 60% of people who seek mental health services end up being prescribed medication and no access to talk therapy. So there's that reversal that has occurred. Like, why has that occurred? In the book, I make an argument that one of the main reasons for that occurring dates back to the release of Prozac in the 1980s, that Prozac was in a very sophisticated way marketed to primary care physicians, not psychiatrists, because Eli Lilly knew at the time that they could open up markets that way. So they marketed to primary care physicians. They marketed Prozac as a safe and effective drug, which essentially established primary care physicians as frontline mental health professionals, where primary care physicians now felt that they had another tool in their tool bag to be able to help people in need. And gosh, 40, 50% of people that end up in a primary care physician's office, there's always a psychological component to their medical problems. So a lot of primary care physicians now felt fortified in treating patients with mental health issues, whereas formerly they would refer out to a psychotherapist. So almost overnight, you saw a 50% reduction in referrals for psychotherapy because of that. So, so there's that going on. Then with managed care, you had the underfunding of mental health. Reimbursement rates currently for psychotherapy are below what they were in the 1980s, approximately $70, $80 a session, right? That's what therapists were charging back in the 1980s. So, and I think insurance companies know that there's an oversupply of therapists out there, and that in their therapy networks, there's a steady stream of inexperienced beginning therapists that can fill the ranks of networks as more experienced therapists exit them. So, so then by underfunding psychotherapy in that way, by keeping low reimbursement rates, they realize that there's not going to be any upswelling of protests around that, certainly in the mental health community, because of that. And you get a lot of cost shifting going on. So high deductibles, high copays, rejection of claims based on a very rigid medical necessity criteria. All of that results in cost shifting, where clients then have to bear the financial cost of therapy. And the more clients have to bear that cost, the more likely they are to kind of deprive themselves of necessary care, right? So you have that going on. And then finally, in the world of academia, and I believe this is an ethical issue. And I've actually written 3 articles in the past year, one of which was in the journal Psychotherapy. The other one is in Ethical Human Psychiatry and Psychology. And the other one is in the Journal of Humanistic Psychology, where I go after the monoculture of cognitive behavioral therapy that is permeating academia right now on ethical grounds. The main one being, I would say, not the only one, but the main one being that we are under preparing a new generation of therapists to acquire the clinical relationship building skills that that allow for therapy getting off the ground with the average client, to be able to engage clients in meaningful ways, where clients feel listened to, heard, where they want to return. We have an awful dropout rate right now. About 40 to 50% of people entering therapy drop out within 1 or 2 sessions. Approximately about 9% of clients who enter therapy get 20 or more sessions, right? Stick with it for 20 or more sessions. Jonathan Shedler and I, in the article on Psychotherapy Network, I think convincingly argue that for the average anxious and depressed client, it takes 1 to 2 years of therapy for meaningful and lasting change to be obtained. And I think, ethically, in clinical training sites around the country, and in graduate programs, mostly doctoral programs in clinical and counseling psychology, we're not preparing therapists to embody the clinical relationship building skills, to engage clients, keep them in therapy so that they can benefit from it. And it's creating these massive psychotherapy dropout rates, which ought to have alarm bells going off within the profession. And that's why I wrote those 3 articles. Yeah.
Well, you have the research, but there's also something very, to me, very common sense about what you're saying, that if what underlies our problems are the most personal, the most deeply meaningful psychological issues and feelings, then of course we're not going to open up to someone we just met, right? That's going to take time to unfold. I wanted to talk about CBT and academia. And I don't know if you've had a similar experience, but I recently had someone in my life say to me, what they were asking for my help finding a therapist, which is, an occupational hazard when you're a therapist, but not a hazard. I enjoy doing it. But they said, well, I Googled this issue that I'm having that I want help with, and I looked online, and what I read is that CBT is the evidence-based treatment for this problem. So how do you respond to that? How might you respond to that?
Well, I could give you a diplomatic answer, or I could give you an iconoclastic answer to that question. Take your pick. I could answer both. I mean, let's be diplomatic. I mean, depending on the nature of your family member's problem, if it's a circumscribed phobia or a discrete trauma, and that person's life is not particularly complicated, and they're somewhat concrete and solution focused in their life orientation, go for it. Give it a try. I think these abbreviated treatments, solution focused treatments, have a place for clients like that. But unfortunately, that's not what most clients are like in the everyday world of clinical practice. So if your family member's problem is basically the tip of an iceberg, and that their anxiety is due to that the true causes of their anxiety is multifaceted, and that you give them an opportunity to kind of explore it, and before long you're finding out that they didn't really deal with their parents' divorce when they were little kids, or they are stuck in a loveless marriage, or they are feel characterologically ill-disposed to be a good parent, or any number of other things, then I would say that to be suspect of those treatments that are being promoted and sold under the banner of science. There's all sorts of, I would say, hey, actually most evidence, the most scientific evidence, most empirical evidence is there for what we call contextual factors in the field. That I would say go look for a therapist and shop around. You might get lucky the first time, but it might take you 5 different therapists before you find a good fit, and preferably be someone that the science verifies as embodying the very characteristics that lead to effective therapy. A therapist who's empathic, genuine, caring, who knows how to establish an alliance where they have a real investment and a real co-responsibility for how problems are defined and worked on in therapy. Favor those qualities, both for personal reasons and for scientific reasons.
What you're talking about is something I actually sense that most people outside the field aren't aware of, that in academia, in research, when we study people, we're studying people with one discrete problem. So like panic attacks. And maybe at most we'll have, what's called a comorbid condition. Maybe someone has anxiety and depression. But there's such a difference, as you're saying, between those type of very discrete problems and what actually brings people to therapy in the real world. And I think you gave some great examples, which very much lines up with my experience of the kind of existential dilemmas that bring people to therapy. I wanted to read a quote from the book. So in this passage, you're describing your interviews with psychology and social work trainees regarding their comfort with having manuals to fall back on while conducting therapy. So you say, I refrain from wondering aloud how much having a worksheet to stare down at and a tight agenda for each session serve to their own self-protective needs, rather than any deeply meaningful therapeutic goals of the client. Insecurities for novice therapists abound. The need to feel productive, clever, and on top of it to prove one's educational credentials, a compulsion to do therapy the way a supervisor mandates for fear of retribution, the desire to control the reverberating emotional effects of clients' chaotic, impossible, anxiety-ridden life narratives. all these insecurities get in the way of taking the client's lead and truly listening to what's on his or her mind. I really loved that paragraph, and it just made me think of, just reminded me of the terror that I felt as a new therapist, sitting in the room with a patient, really having no idea if I was going to be able to help them. So it makes me wonder, okay, if manuals aren't the answer, what is? Like what actually helps us as new therapists, as not so new therapists, to contain our anxiety and just be open to hearing what someone else has to say about their life?
I mean, at one level, there's a very easy, straightforward answer to that question. I mean, I don't know about you, but my own personal therapy was the fundamental platform that allowed me to acquire sort of a relative immunity to being overly anxious as a therapist in the room with clients, right? I mean, there's no substitute for one's own personal therapy and plunging into one's own personal therapy as foundational in terms of just knowing the basic interpersonal rubric of conducting therapy. So, I mean, when I was starting out, not such a bad thing. I think I mimicked the style of the therapist that I had. And without that, I would have been, it would feel like being airdropped, out of a helicopter. It's just, so that for me was foundational. I'm a big believer too in the best therapists being wounded healers. You don't have to have gone through exactly the same thing as clients have gone through to be able to, relate to them in meaningful and productive ways. But you certainly have to, I think, be opened up to core aspects of the human condition. I kind of sometimes jokingly, sometimes seriously refer to good psychotherapy as the secular cure for the 7 deadly sins: lust, vanity, greed, sloth, envy. These core primary emotions, I think, are at the heart of most human problems. And the more you as a beginning therapist, through your own therapy, acquaint yourself with and familiarize yourself with those sort of primary primal emotions, if you will, and get better expressive mastery with them, then that is a powerful form of emotional immunity when you're in the room with clients who are feeling similarly.
Personal experiences in therapy were key for me as well. And I don't know about you, but I'm hearing from students that that's less and less emphasized in graduate programs, which is a shame. So you cite this study in the book, which I thought was fascinating, which is found that CBT therapists overwhelmingly select psychodynamic or humanistic therapists when seeking their own therapy. How do you explain that?
Once again, there's the diplomatic answer, and then there's the snarky, iconoclastic answer. Well, there is a certain hypocrisy to that, right? I mean, I'm going to start with the snarky answer. There's a certain kind of hypocrisy, a certain kind of elitism that, me as a cognitive behaviorally trained therapist, my problems are of a magnitude that of a personal nature, whereas clients that come to see me aren't, but more kindly, more diplomatically. I think what happens to all of us is that the further out from the confines of academia and the further out from prescriptive forms of therapy that we're required to perform because our competency is being evaluated in that way. The further out from that we go, and for those of us that get into private practice, we're less accountable to that kind of superstructure. And we're more accountable to the real pain and suffering of human beings that cross the threshold into our offices, and that require of us something that gives them relief. And so I think there's a baked-in, built-in humanistic transformation that therapists go through because of that. And so the best answer I have for you is that perhaps there's a humanization process that goes on for all therapists, regardless of their orientation. And so that's my best answer to your question, that then, makes cognitive behavioral therapists wanna, it opens them up to the existential nature of human problems, and the explorative, and a desire to have explorative, non-directive, open-ended therapy for themselves.
Right. I think you're touching also on another issue with how siloed academia is when it comes to mental health. Like it's really not integrated. It's very separate than the rest of, public health, the rest of mental health, people in private practice. So I really liked your chapter on psychiatric medication, and I thought it was very very balanced, which I think is rare when you read about this. You called yourself in the chapter an uncompromising pragmatist when it comes to psychiatric medication. So what did you mean by that?
I'm a big believer in kind of evolutionary psychology. I don't think humans are kind of designed to survive and thrive, and the kind of current cultural context that we find ourselves in. I especially feel that way after watching a documentary last night on TV, Our Social Dilemma, I think it's called, about the kind of the manipulative effects of social media, right? So I say, because we're not designed to like really survive and thrive in the kind of environmental conditions that we find ourselves, we need to try everything and anything to adapt better, to thrive better, to flourish better, to get through life, and hopefully with as happy an outcome as possible. So, whether that involves legal pharmaceuticals, illegal pharmaceuticals, hobbies, diet, this, that, the next thing, right? So that's my kind of overarching framework. So when it comes to medications, if a person's functioning is at stake, in other words, if they're in such dire straits, if they're in such a kind of a disabled place in their life, where if something fast doesn't occur to get to and to assist their functioning, or to support their functioning, and their condition can worsen, then those are the conditions under which I often start to kind of move in the direction of kind of medication or medication referral. I mean, often the case in point there is, say kids that are disorganized and impulsive and distractible at school. And there's the question of possible ADHD. And if they don't pull it together fast, their enrollment at that school is in jeopardy, or the harmony of the household is in jeopardy. And there's a real urgency to the situation. Those are the conditions under which maybe I will refer, like a kid to for a medication consultant, or a family for a medication consultant, with the understanding that it's perhaps a temporary solution, not a confirmation on my part that they've got a disordered brain that needs to be chemically treated. No, it's a quick pharmacological intervention, among other things, stabilizing the structure at home, stable routines at home, getting involved with the school, this, that, and the next thing, that bolsters that kid's function at a critically important time in their lives, where you then examine and re-examine over time the need for medication, and make no mistake about it, constantly weigh the pros and cons of the therapeutic benefits and the non-therapeutic side effects of those medication. And that dynamic is the vast majority of the time always present. You need to keep that discourse constantly going. Is the medication helping more than it's hurting, or hurting more than it's helping? And to have a transparent conversation about that, and a preparedness to change medications, stay on medications, lower dosage, or get off them fast, depending on the outcome of that conversation. So that's a kind of a window into my pragmatic mind, on these matters.
And those kinds of in-depth discussions, of course, can happen if your primary care physician is giving you a script. You're really, I think you give some great clinical examples in the book about the kinds of really, specific and in-depth conversations you have with people, grappling to understand the meaning of taking medication, as you say, the impact of taking it, how that changes over time, how that changes when their relationships change. And it's a very complicated picture. And
they're not going to have that conversation with the psychiatrist in the typical 15-minute med consult. Yes. So, I mean, whether we like it or not, I think as therapists, we're kind of forced to, have conversations like that with clients around meds. Yeah.
So going back to managed care, I was rereading Saving Talk Therapy, and it happened to be the same week that a lot of professional listservs I'm on were discussing these proposed cuts to Medicare reimbursements. And this is part of a trend you talk about in the book about reimbursement rates for mental health care staying stagnant or declining over the past several decades. So can you tell us, why is this happening? Why are these declines going on?
Big declines in
the reimbursement rates.
Yeah, it's hard to know. I mean, other than the profit motive in terms of with insurance companies, there's always that fear that somehow or other that psychotherapy will be overutilized when it's underutilized, right? I mean, about at any given time it's inaccurate, but about at some point in their lives, about half the population in America will meet the criteria for a mental health diagnosis, but only about 3% ever enter therapy, right? So there's this fear on the part of insurance companies that psychotherapy will be overutilized. And it partly dates back to the state of affairs before managed care, where there were abuses in the system. When under indemnity insurance plans, in particular, a lot of teenagers were sent to very expensive residential treatment facilities, and there was, overbilling, just rebranding of diagnoses, upbranding of diagnoses, and to kind of justify the need for intensive care, which was costly. And so we're still, I think, as a profession, suffering from the long-term consequences of some of that. But I think also, and this is a great fear of mine, that insofar as the cognitive behavioral, juggernaut takes over our field, manualized treatments don't involve that much sophistication to perform. And, you can train a relatively inexperienced person to perform them. And my fear is that under, let's say, a Medicare for All program or a single payer plan, that you'll see these forces at play that will favor evidence-based treatments because they're shorter term, they're less costly. They don't involve a lot of sophistication to perform. So on the face of it, it doesn't seem like a real expertise, if you will, that's worthy of a healthy remuneration, from a monetary standpoint. But all under the banner of evidence-based practice and the endorsement of the best that science has to offer, that can lead to kind of the deep professionalization of the field and the underfunding of psychotherapy. And that all scares me, frankly. Yeah. We will need to get good at doing something that we're not that very good at, and that is advocating for higher fees. which kind of goes against the grain for a lot of us that got into the profession for humanitarian reasons, not to, get rich.
Well, you talk about this in the book, right? This thing that you hear, well, we can't offer everyone high quality open-ended treatment that's relationship based because people would just be in therapy forever. But you find that like the research shows that's not the case. That's not how people utilize therapy.
Even if it was the case, Bevin, there's a lot of good research out there showing that that's less costly than people going to medical doctors and medical specialists for specious reasons. Theoretically, you could pay reimbursed therapy at $100 a session for 1 to 2 years, and the cost savings of that in terms of just the specious medical services, or the unnecessary medical services that get paid for, really from an economic standpoint benefit us all. So we need to be making kind of more arguments like that.
Yeah. I wanted to go and in the direction of asking you about the inspiration for writing this book, because in the beginning you write about the heyday of, as you call them, the humanistic Freudians. So people like Erich Fromm, Karen Horney, who wrote these books that were really popular amongst a wider audience. And today, of course, for the most part, psychoanalysts, we talk to each other, or we talk to others in the field. And I wanted to know why you really wanted to write for a general audience.
As a young man, I was sort of a troubled person. I was sort of an insecure person. And not only did my own personal therapy kind of allow me to acquire kind of an authentic sense of self, but books that I accessed at the time, I'll never forget as a young man picking up Escape from Freedom by Erich Fromm and devouring it, and then going to the local used bookstore and purchasing and reading every single book that he wrote. I'll never forget reading Rollo May's like Love and Will, and Karen Horney's books, and they really, in a very sophisticated, thoughtful way, spoke to kind of what I was going through, and gave me kind of a lexicon and framework to kind of understand my own pain and suffering in a language that was fairly accessible to kind of a lay, educated reader. And so I feel like we've kind of lost that. I'm thinking maybe the last book that I can think of that sold, like maybe it was The Drama of the Gifted Child by Alice Miller. When was that? Was that the late 80s?
I think in the 80s, yeah.
There were always, books like that that were big sellers, right? And so I feel like we've kind of, those of us that identify with the psychoanalytic and the existential humanistic traditions, I mean, I feel like that tradition of like writing for a general audience has been lost. And so I was determined to write a book, not just for fellow professionals, but that clients could pick up, and that they could, and that I strove to kind of like really distill complicated psychoanalytic ideas, complicated existential ideas, if you will, into kind of a language that people could kind of, that was accessible to the lay public. That was extraordinarily important to me. Yeah, still is. Yeah.
Yeah. Let me ask one more question about training and education. So I supervise psychologists in training, and I was really struck reading the book by this idea that what is at the heart of the therapeutic encounter is not the application of a specific technique, but it's the personhood of the therapist. So that really raises the question for me: what should our education of therapists focus on? How do we help people become good therapists? And you brought up, personal therapy, which of course is vital. Any other thoughts?
I just wrote an article about that that's going to be published in Psychoanalytic Inquiry next year, because I do feel like it is a real ethical issue that we're not preparing a generation of therapists to kind of acquire the clinical relationship building skills that engages clients in ways that makes them want to, be in therapy, benefit from therapy, stay in therapy. And so we have this awful psychotherapy dropout crisis. So it is an issue of ethical concern to me. you know, in a perfect world, we would select candidates for graduate school that are aspire to be therapists based on their empathic abilities, how integrated they are as a person, um, their life experiences, how adept they are at internally managing their emotional lives. These sorts of qualities. Ideally, that would be the selection processes, not budding scientists. But will that ever happen? I don't know. It actually happened in my own education, so I feel very fortunate about that. I mean, I got a master's degree in existential phenomenological psychology from Seattle University back in my mid-20s, and the whole program was structured around one's the inextricable link between one's personhood and one's effectiveness as a psychotherapist. So I feel fortunate myself to have been educated in that manner. I mean, I think the best graduate education for a therapist, and I'm kind of, you know, similar to Freud in this manner, would be a non-scientific, non-medical education that like what you take courses in anthropology and philosophy and literature, and that you get a deeper and deeper understanding of the human condition, literary analysis, movie analysis of like a character analysis that give you kind of a access to rich, descriptive, phenomenological representations of human pain and suffering, and interpretive frameworks for understanding that. Yeah, and lastly, we need to revive the tradition of case studies. You know, access to really good case studies and all those great psychoanalytic articles and books back in the day was one of my primary learning mechanisms. I would read these, like, you know, case studies and see myself in them, see the clients I was treating in them, see the problems of future clients that I would reference back to case studies that I read. And it gave me templates, descriptive, interpretive templates for really learning about how to conduct psychotherapy. And I think that tradition of case studies and our scientific, you know, atmosphere right now has been lost, and we absolutely need to revive that.
Yeah,
Our training programs. Yeah.
I'm in agreement. So the book Saving Talk Therapy came out a couple years ago. How are you feeling these days? Are you optimistic about the future of traditional talk therapy? Are you feeling more pessimistic since it came out?
To be honest with you, I'm moving into different territory in terms of a new book that I'm writing and some articles that I've written. But I think we're gonna. I am so grateful to PsiAN as an organization to like really bang the drum, if you will, to counteract the forces at play that are threatening quality talk therapy right now. So I think that they're aware, not only my book, but you know, there's smarter people than me in PsiAN and more energetic people than me in PsiAN. They're aware of the forces of play, and they are targeting them in very clever ways to kind of like push back. I think we always, that this may not, for those listeners that are uh, 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 that have social justice issues on the forefront of their minds. I actually am a little bit more conservative in terms of like, to preserve good talk therapy, we will have to fight for adequate and reasonable remuneration for our services. That's going to be a big one. Advocating for better reimbursement rates, right? And for approval of more sessions. Those as long, you know, those will always have to be front burner issues. I think too, we may need to embrace a certain kind of deception that might go against the grain for a lot of therapists. And what I mean by that, I call it playing the game. When I'm on the phone with an insurance company, I am extraordinarily good at talking with medical jargon and discourse to get my clients' therapy approved and paid for. I don't I'm not rigidly principled and trying to kind of, advocate for more services based on my own more humanistic understanding of therapy. That would get nowhere. So you got to play the game, got to be sort of deceptive. You got to kind of know what works within the medicalized system in order to kind of actually represent the client and what they need. And so that requires a certain amount of deception. I think we may have to be even more deceptive in this day and age, kind of keep getting service, mental health services sort of approved and paid for. Yeah.
Well, since you referenced it, tell us what are you working on these days?
I have a book that I'm working on with a working title. It's Couples That Last, Breaking the Love Code. And it's a book about just sort of contemporary, love, sex, and the contemporary era from a kind of a psychoanalytic perspective, attachment theory perspective, existential humanistic perspective. I'm also in the book, I want to present a model of long-term partnership that gets away from a moral framework to what I call an ethical one. So away from the role of kind of organized religion and the historical effects of all of that, and how we think about love and sex, and more towards an ethical one in terms of just issues of fairness, justice, loyalty, and how they play themselves out in long-term relationships. So I'm sort of playing with all these ideas. I just published a couple of articles, one in a journal called Existential Analysis and another one in the Journal of Humanistic Psychology on an existential approach to couples therapy, that sort of laid the groundwork for some of the ideas that I'm going to write about in the book. And I'll end with this. It's a book that I want to incorporate a lot of humor in. I think as therapists, we take ourselves way too seriously. We talk about doing the work of therapy as if it's some kind of religious, undertaking. I think we just need to loosen up. We need to relax. We need to be more lighthearted. We need to help clients embrace the humor and absurdity of the human condition and how they live their lives. And so those themes, there'll be a lot of those kinds of themes in the new book that I write. It should be an entertaining book.
Well, I can't wait to read it. And I'm taking that message with me through the rest of my day. I wanted to say thank you so much for speaking with me today. It was really a pleasure. And thank you everyone for watching. I also want to say the Psychotherapy Action Network is a 100% volunteer-run nonprofit, and you can learn more about our work at PsiAN.org. Thank you so much, Enrico.
Thank you, Bevin. Much appreciated.